I'll start sharing the slides.
Yes. Yes, visible, sir.
Sandeep sir, can we just start in another couple of minutes? We are having some issue with the link. Can you just give us 2 minutes, sir?
Okay, fine.
Okay.
Sir, just 2 minutes. I'll just update. Yeah.
Okay.
We're having some issue at the attendee link end. Yeah, just 2 minutes. Netcast team, kindly check. The attendees are not able to see the video. The video is not being able to is not visible to the all the attendees. We are getting the response. Just check. Netcast team. Okay. Sir, we have resolved the issue. Sir, now it's okay. So we can go ahead. Yeah. Thank you, sir.
Okay.
Thank you. Extremely sorry.
Yes, sir. Please.
Good evening to dear friends and colleagues and company higher people and representatives. I would like to talk to about the latest guidelines from European Society of Cardiology 2021 with reference to both acute and chronic heart failure treatments. So there were a lot of changes or slight modifications of 2016 guidelines. So I'll just touch upon those highlights of that. So regarding the right heart catheterization, as far as heart failure is concerned, where we should consider. So in patients with constrictive pericarditis or in patients with restrictive cardiomyopathy, congenital heart disease, and high output states, the class of recommendation is 2A. And right heart catheterization in patients who present with heart failure with preserved ejection fraction, in order to confirm the diagnosis, it comes as class 2B. And heart failure with reduced ejection fraction, that is HFrEF, the SGLT2 inhibitors like dapagliflozin or empagliflozin are recommended in patients with HFrEF to reduce the heart failure-related hospitalization, rehospitalization, and mortality. The class of recommendation is given as class 1. And there is a drug called vericiguat, which increases cyclic GMP in the myocardium and improves the heart failure symptoms. So this is indicated. This may be considered in patients who have class 2 to 4 symptoms, despite being treated with ACE or ARNI, beta blockers, MRA to their maximum tolerated doses, in order to reduce both the hospitalization and mortality, and the recommendation is 2B. So this is a new thing that has come. In patients who have mid-range, the mid-range has become mildly reduced ejection fraction. So you can call it as mid-range or mildly reduced EF. So the ACE inhibitors, if not tolerable, ARBs, then beta blockers, then MRA, like reduced ejection fraction, all these drugs can be used in patients with heart failure with mid-range ejection fraction. Also, the class of recommendation is 2B. And the sacubitril valsartan, that is the ARNI, also can be used in this, and the class of recommendation is 2B. Regarding heart failure with preserved ejection fraction, screening for and treatment of specific etiologies and cardiovascular and non-cardiovascular comorbidities like diabetes, hypertension are recommended in patients with heart failure with preserved ejection fraction. The class is class 1 recommendation. Self-management strategies like monitoring the blood pressure, monitoring the blood sugar, monitoring the pulse rate, oxygen saturation. After this COVID era, the saturation monitoring has become routine, and it has become important and more relevant. So the self-management strategies are recommended to reduce the risk of heart failure hospitalization and mortality in patients with heart failure symptoms or who are on artificial treatment. So they can do this management, self-management strategies. The class of recommendation is 1. And then that can be either home-based or clinic-based programs in order to improve the outcomes. And it is again class 1. And vaccination, influenza vaccination and pneumococcal vaccination should be considered in order to prevent heart failure hospitalization. Class 2A is the recommendation. And non-invasive and telemonitoring may be considered for patient with heart failure in order to reduce the risk of recurrent CV and heart failure hospitalization, cardiovascular death. Again, it is 2B. Patients who have advanced heart failure, there is something called mechanical circulatory support like left ventricular assist devices or right ventricular assist devices, and so on and so forth. So the long-term MCS, mechanical circulatory support, should be considered when the patient has a good knowledge about how to handle the device and has a good psychosocial support, and he will be good compliant with the whatever instruction we give. Such patients, you can submit them for long-term MCS, the class 1 recommendation. Heart transplantation is recommended for patients with advanced heart failure and refractory to medical or device therapy, and who don't have any absolute contraindication, again, the class 1 recommendation. Continuous inotropic support and vasopressors may be considered in patients with low cardiac output and evidence of organ hypoperfusion as bridge to mechanical circulatory support heart transplantation. The recommendation is 2B. And regarding the heart failure hospitalization, how to manage this. So what is important is, now already patients who are hospitalized, we have to make sure that prior to discharge, their congestion, both physical and symptoms, have been completely cleared off before discharging the patient. So it is class 1 recommendation. And invariably, when we hospitalize the patient, whether it is acute or chronic, they'll be on intravenous or parenteral medications, which may be a diuretic or a vasodilators or a inotropic support. So such parenteral therapy, we have to make it to oral medications prior to discharge. So again, class 1 recommendation. And once we discharge the patient, we have to call them for a review, which is usually 1 to 2 weeks after discharge, in order to make sure that there is no recurrence of congestion, so that we can prevent the hospitalization by calling at 1 to 2 weeks of discharge. And we can make sure that there is no drug tolerance, check the electrolytes, check the creatinine, make sure you adjust the diuretics, make sure you adjust the medications, like you may be on a small dose of ARNI. The ARNI dose has to be 200 twice daily, the maximum tolerated dose. So we would have started with 50 milligram twice daily. Now that you can step up according to the blood pressure, according to the creatinine, electrolytes. So up titrate of the evidence-based therapy has to be done. So for that, we have to call the patients at 1 to 2 weeks. So the class of recommendation is 1. And if patient has a heart failure with atrial fibrillation, obviously there is 2 things. One is rate versus rhythm control. The second is prevention of stroke. So need for a long-term oral anticoagulant should be considered for stroke prevention in patient with atrial fibrillation, especially when the CHATS-VAS score is 1 in men and 2 in women. The class of recommendation is 2A. And patients, if he has a heart failure with chronic coronary syndrome, so all these years we were calling chronic stable angina, now it is no more chronic stable, and the European Society of Cardiology has made it as chronic coronary syndrome in order to emphasize the importance of treating these patients. CABG, so where will you consider revascularization by bypass surgery in patient with CAD with heart failure? So whenever patient has a multi-vessel disease, and especially if diabetic, then CABG should be considered. The class of recommendation is 2A. And if same patient, where will you consider PCI? So PCI can maybe considered as the alternative to CABG after a heart team evaluation, considering the coronary anatomy, considering the comorbidities, and considering the surgical risk. If surgical risk is very high, if comorbidity is not much, and the coronary anatomy is suitable for PCI, then we can consider PCI in multi-vessel disease. Also, the class of recommendation is 2B. And regarding coronary revascularization, may be considered in order to improve the outcomes in patients with heart failure with chronic coronary syndrome, when the coronary anatomy is suitable for revascularization, especially if patient has proximal stenosis or left main stenosis. These are all lesions which, when we revascularize, they will do very well, and the ejection fraction tends to improve. Regarding valvular heart disease and heart failure, what is the management says? The ESC guideline says that as far as the management of aortic valvular problem, both aortic stenosis, now that we have percutaneous non-invasive TAVI versus surgical aortic valve replacement. So TAVI or surgical valve replacement is recommended in patients with heart failure with severe aortic stenosis in order to reduce both the mortality and as well as the morbidity, the class 1 recommendation. And the choice between the TAVI and surgery should be made by the heart team. And it should be according to the individual patient preference, the features like age of the patient, what is the surgical risk involved, what is the clinical, anatomical, and procedural aspects. Weighing the risk-benefit ratio, then we have to put forth TAVI versus surgery, which is better. So that is the recommendation is class 1. And similarly, we have now recently percutaneous mitral valve repair for patients with mild regurgitation, especially patients who have mitral valve prolapse-related mitral regurgitation. So percutaneous edge-to-edge mitral valve repair should be considered in carefully selected patients with secondary mitral regurgitation who are not eligible for surgery and not needing coronary revascularization. They don't need bypass surgery. They don't need bypass surgery. So not needing coronary revascularization, they are not suitable for surgery. Such patients, we can consider percutaneous mitral valve repair, especially if they are symptomatic despite optimal medical therapy in order to reduce the heart failure hospitalization. So the class of recommendation is 2A. In same thing, and there is the criteria for fulfilling the reduction of heart failure hospitalization is not fulfilled, then it becomes class 2B. That is, when the criteria for reducing the heart failure hospitalization is not fulfilled, but remaining all the parameters are fulfilled for a mitral valve repair, then the class of recommendation becomes 2B from 2A. Heart failure with diabetes. As we know that SGLT2 inhibitors, all the groups, that is canal, DAPA, EMPA, ertuglizone, sotaglizone, all the drugs can be considered when there is diabetes in order to reduce the hospitalization for heart failure, major cardiovascular events, end-stage renal dysfunction, and cardiovascular death, class 1. That is irrespective if of the patient doesn't have a heart failure. To reduce the hospitalization of heart failure, to reduce the major cardiovascular events and the renal dysfunction and the mortality, we can use any drugs. But if patient has already a HFrEF, that is ejection fraction is already below 40%, then the drugs, only 3 drugs, dapagliflozin, empagliflozin, sotagliflozin are recommended in patient with diabetes who have HFrEF in order to reduce the hospitalization for heart failure and cardiovascular death. The class of recommendation is class 1. One drug which is absolutely not recommended in patient with heart failure, that is DPP4 inhibitor, saxagliptin. The class of recommendation is 3. So it should not be used in patients with heart failure, saxagliptin. And patients with HFrEF with diabetes, DAPA, EMPA, and SOTA can be used, class 1. If patient doesn't have HFrEF, in order to prevent the hospitalization for heart failure, then you can use any of the SGLT. Regarding heart failure with iron deficiency, this is one of the hot topic nowadays. You can see a lot of meetings with reference to this. What is important is, it has been very well said that when you correct the iron deficiency, the need for hospitalization comes down because of heart failure. So what is important is whenever we see a patient, don't look for anemia. Look for iron deficiency, because anemia takes a little longer time. Before that, you can detect iron deficiency, you can correct it, patient can become better symptomatically. So what you have to look for is just ask for a full blood count, a complete blood count, a serum ferritin concentration, and TSAT, transferrin saturation. So intravenous iron supplementation with FCM, that is ferric carboxymaltose, should be considered in symptomatic heart failure patients who have recently hospitalized for heart failure with an ejection fraction less than 50%, whose iron deficiency has been confirmed because of serum ferritin level being less than 100, or if serum ferritin between 100 to 299 nanogram per ml, with a TSAT less than 20%, in order to reduce the risk of heart failure hospitalization, better you give intravenous iron supplementation and correct it you can prevent and you can reduce the risk of HF hospitalization. The class of recommendation is 2A. And routine use of erythropoietin in patients with anemia and heart failure is not recommended, and the class of recommendation is class 3. So erythropoietin usage should have a specific indication for the usage, like patient with renal failure, patient with rheumatoid arthritis, something like that. Routine use of erythropoietin in patients who have anemia and heart failure is not recommended. This class 3. So please note it. And regarding heart failure and cancer, as we know that some of the cancer chemotherapy can produce myocardial dysfunction, LV ejection fraction comes down, and they can develop heart failure. So it becomes important to know that patients, before they start the treatment for cancer, we have to make sure that they don't get into this heart failure problem. So what we should do is look for history of risk factors for cardiovascular disease, or if patient had previous cardiotoxicity or already patient had exposure to cardiotoxic agents. We should make sure that he goes for a cardiovascular evaluation in the form of ECG, echo, before starting the anti-cancer therapy. The class of recommendation is class 1. And patients who are already going to have the chemotherapy, and if the rejection fraction is 10% or more comes down from the baseline, then becomes mandated to keep them on ACE inhibitors and beta blockers, preferably carvedilol, which has shown very good response in patients who have cardiotoxicity because of cancer chemotherapy, in order to bringing back the LV ejection fraction. A baseline cardiovascular risk assessment should be considered in all cancer patients and who are going for a cancer treatment, who have a potential to have a heart failure. The class of recommendation is 2A. So before submitting a patient with cancer chemotherapy, make sure that if they have cardiovascular risk factors, do a thorough cardiovascular evaluation before starting the treatment. That's what the guideline says. The recommendation is class 1. And regarding heart failure with amyloidosis, it has been clearly said that patients who have hereditary transthyretin cardiomyopathy with a class 1 or 2 symptoms, in order to reduce the symptom, we can consider a drug called tafamidis to reduce the hospitalization as well as mortality, the class 1 recommendation. Similarly, this tafamidis is recommended in patients with wild type transthyretin cardiomyopathy who have class 1 or 2 symptoms, to reduce same symptoms, hospitalization, and mortality. So tafamidis is a new drug which has come and which can be considered only in patients who have amyloidosis because of TTR mutation. So regarding the diagnosis aspect, if we see invasive coronary angiography, where we should submit patients for invasive coronary angiography. As we know that whenever there is high probability of ischemia in non-invasive test, you have to submit. But if patient has an intermediate to high probability of having a CAD, which is evident from the non-invasive stress test, in patient with HFrEF, those patients should go for invasive coronary angiography. The class of recommendation previously was 2A, now they reduced it to 2B. And similarly, where will you submit CT coronary angiography for your patient CT coronary angiography? So patients whose non-invasive stress test showing that low risk or low to intermediate possibility of having a CAD, then you can do CT-CAG. Instead of regular invasive coronary angiography, you can submit for CT-CAG. The class of recommendation has come from 2B to 2A. They have promoted from 2B to 2A. And as I already mentioned, right heart catheterization should be considered, especially in patients with pulmonary hypertension, where there is a possibility of reversibility. So if you are going to submit a patient for valvular heart disease with pulmonary arterial hypertension for a valvular correction surgery, make sure that the pulmonary arterial hypertension is reversible. If patient has a congenital heart disease and pulmonary arterial hypertension, make sure that pulmonary arterial hypertension is reversible. If already pulmonary arterial hypertension become permanent or persistent, then doing such a high-risk procedure of correction of a valve or structural heart disease may not help. So the class of recommendation has come down from 2A to 2B for right heart catheterization in patients who are going for surgery prior to surgery. Make sure that do a right heart catheterization in order to make sure that pulmonary arterial hypertension is reversible. And regarding the indication for implantable cardioverter defibrillator, ICD, so what is happening is, ejection fraction equal or less than 35%. Not that every patient with ejection fraction less than 35%, as soon as you diagnose, you submit them for ICD. You have to put them on optimal medical treatment and wait for at least 3 months. So 3 or more months, still ejection fraction is 35 and below, still patient continues to have class 2 to 3 symptoms. In order to reduce the risk of sudden death and all-cause mortality, ICD should be considered. So the class of all these years, it was class 1, now it has come to class 2A. But this also you should consider only when you know that the patient is going to survive more than 1 year. If patient has a cancer and he is going to survive only for 6 months, there is no point in putting an ICD for him. So you have to make sure that he will survive for more than 1 year. His ejection fraction is less than 35. He has received the optimal medical therapy for 3 months and still continues to have class 2 to 3 symptoms. Then you can put ICD. The class of recommendation is 2A. And similarly, cardiac resynchronization therapy, CRT, or triple chamber pacemaker should be considered whenever patient has a QRS duration of 130 to 149 milliseconds. That's wider the QRS, LBBB morphology, and his ejection fraction is less than 35%, who is already on optimal medical therapy. Then you can consider them if continues to be symptomatic despite the optimal medical therapy. Then class of recommendation is come down from 1 to 2A. Because of, I think the army has come, so army is making much symptomatically much better in patient with less than 35% with heart failure. So probably that is the reason the class of recommendation has come down from 1 to 2A for CRT. And regarding patients with ejection fraction less than 35% who have received a conventional pacemaker or an ICD and subsequently develop worsening of heart failure despite optimal medical therapy, then you can upgrade to CRT. It has from 2B, it has switched to 2A. That is, patient has already had a pacemaker, maybe because of a complete heart block or maybe because of a sick sinus syndrome. And patient has already had an ICD because of some reason. And now he has developed a heart failure and he is not responding to heart failure despite optimal medical therapy. Then you can upgrade from single chamber ICD or double chamber ICD to a CRT with ICD. So it can be so CRTD, we can upgrade to CRTD. So that is the recommendation from 2B, it has upgraded to 2A in this 2021 heart failure guidelines. And combination, say always now we tend to use diuretics like loop diuretics like Lasix or torsemide, furosemide and torsemide in the heart failure patients with in parental form. But when they don't respond, the edema is not responding purely to loop diuretics. That is the time where we can use a thiazide type diuretics like metolazone. We can add a small dose of metolazone that will help. It will potentiate the effect of loop diuretics, or it will break what we call diuretic resistance. So the recommendation has come from 2B to 2A. So using a thiazide-like type of diuretic in addition to loop diuretics will help to prevent or to break the diuretic resistance and to improve the response to edema. Regarding the acute heart failure with systolic blood pressure more than 110 millimeters mercury, we can consider intravenous vasodilators may be considered as the initial therapy to improve symptoms and reduce congestion. So this is again, the previous guidelines said it was 2A, now it is downgraded to 2B. Regarding routine use of opioids, so patient comes to emergency with some chest pain, immediately we should not rush and give morphine or fentanyl like that. So what they say is routine use of opioid is not recommended. It has from 2B, it has come to 3 now. It is not recommended. Routine use of opioids is not recommended. That is the 2021 heart failure guideline clearly says it should be used only in selected patient with severe or intractable pain or patient has severe anxiety. Then only we should use routine use of opioid. Otherwise, opioid should not be used. Previously, it was 2B. Now it has become 3. The risk of hypopnea and the patient is getting arrested and all is that. Regarding the short term, we saw long-term mechanical circulatory support. Now, short-term mechanical circulatory support should be considered in patients with cardiogenic shock as a bridge to device therapy, to various further treatment. We can use it as a bridge. So the class of recommendation has come from 2B to 2A. It was promoted. And again, the docs, there is the so-called newer oral anticoagulants or directly acting oral anticoagulants are recommended in preference to the warfarin or aceclomine, that is vitamin K agonist, in patient with heart failure, except in two conditions. One is when patient has mitral stenosis, which is moderate to severe, or patient has a mechanical prosthetic heart valve. Only these two conditions we are forced to use vitamin K antagonist. Still, the so-called directly acting or newer oral anticoagulant is not recommended in this condition. So the class of recommendation is class 1, except two entities like mitral stenosis, which is moderate to severe. Mild mitral stenosis with the AF, you can use. Mild mitral stenosis, patient has DVT or pulmonary embolism, still you can use that is rivaroxaban or apixaban or dabigatran. But only warfarin or aceclomine has to be used when you have a patient with heart failure and who have mitral stenosis, which is moderate to severe, or patient has a mechanical prosthetic heart valve. Okay, so that is class 1. And regarding beta blockers, should be considered for short and long-term rate control in patients with heart failure with atrial fibrillation. So the class of recommendation from class 1, it has come to class 2A. And in cases of clear association between proximal or persistent atrial fibrillation and worsening of heart failure symptoms, which persist despite medical therapy, the catheter ablation should be considered for prevention of AF. From 2B, it has come to 2A. In other words, again, this 2021 guidelines insist or more for rate versus rhythm. In that rhythm, it insists now. So previous guidelines, they say rate or rhythm. It is not, if you control the rate, it is good. You need not go for rhythm control all the time. But now, again, they are going for rhythm control. So they are promoting catheter ablation for controlling the rhythm in patient with atrial fibrillation. If you have proximal or persistent atrial fibrillation, and that persists despite medical therapy. So the class of recommendation has promoted from 2B to 2A. And regarding, again, the coronary revascularization should be considered to relieve persistent symptoms of angina in patient with HFrEF and chronic coronary syndrome when the coronary anatomy is suitable for revascularization, which happens despite optimal medical therapy. So the class of recommendation is class 1, 2, it has come to class 2A. And again, SGLT2 inhibitors, I have already mentioned this. Let's skip this slide. And as we know that, what is HFrEF, what is mid-range has become mildly reduced ejection fraction, and what is HFpEF. So everyone knows that below 40% is HFrEF, and 41 to 49% is mid-range ejection fraction heart failure, and preserved ejection fraction is any ejection fraction which is equal or more than 50%. The diagnostic algorithm for heart failure is like this. So patient comes to the ER with symptoms of breathing difficulty. You are examining the patient, the ECG is abnormal. The only one test, if somebody asks you to do, just do an NT-proBNP. If NT-proBNP is 125 picogram per ml or above, then straight away heart failure is confirmed, and you can go for further checkup. If it is normal, then you are ruling out a heart failure. And if suppose NT-proBNP is high or NT-proBNP, you cannot do it because it is not available, then you go for an echo, and echo is abnormal, then you are going to have 3 categories. One is ejection fraction equal or less than 40, another one is 41 to 49, another one is 50 and above. So you can divide them into HFrEF, of mid-range, and HFpEF. So then according to that, you have to treat. So that is how the diagnostic algorithm goes. And this is a slide which shows that, already I have mentioned regarding the implantable cardioverter defibrillator and cardiac resynchronization therapy. You can see that first thing foremost is any HFrEF patient, you have to put them on optimal medical therapy. So optimal medical therapy or the evidence-based medical therapy, what it gets, ACE inhibitor or ARB. who are not tolerant to ACE inhibitor. Now that after this ACE-ARB, now we have ARNI. So first consider ARNI, beta blockers, then mineralocortical receptor antagonist, aldosterone antagonist. Then comes SGLT2 inhibitor. Then comes loop diuretic for fluid retention. So these are all the optimal medical therapy. So you uptitrate to the maximum tolerated dose. After that, if patient continues to have symptoms, and if ejection fraction continues to be less than 35 and his QRS is less than 130, and then if patient is ICD, you can consider ICD. If it is ischemic, LVEF less than 35, class 1 indication. If it is non-ischemic, less than 35 LVEF with less than 130 QRS, then it is class 2A recommendation. If patient has sinus rhythm, patient ejection fraction is less than 35, but the QRS duration is more than 130, then you can go for CRTD. That is CRTD or CRTP. Depends. If QRS is very wide, like more than 150, it becomes class 1 indication. If it is between 130 to 149, it is class 2A indication. And regarding patients who has ejection fraction more than 35 or already device therapy is not indicated or it is not appropriate, it is inappropriate. If still symptom persists, consider therapies with class 2 recommendations. That is other therapies you can consider. So patients who have HFrEF, ACE inhibitor, beta blocker, MRA, SGLT2 inhibitors, ARNI, everything is class 1 recommendation. So HFrEF, all these drugs should be considered class 1 recommendation. And in HFrEF, ivabradine, where will you consider ivabradine? So ivabradine, when the ejection fraction is less than 35, patient is in sinus rhythm, and if the resting heart rate is more than 70, despite treatment with evidence-based dose of beta blocker, that is a maximum tolerated dose of beta blocker, then patient has ARNI, patient has MRA, and the heart, despite that, ejection fraction is less than 35 and the heart rate is more than 70. In order to prevent the hospitalization, re-hospitalization or cardiovascular mortality, we can consider ivabradine the class 2 recommendation, class 2A. And ivabradine should be considered in symptomatic patients with ejection fraction less than 35 in sinus rhythm, whose resting heart rate is 70 or above, who are unable to tolerate beta blocker or who have contraindication for beta blocker. So you started using beta blocker maximum tolerated dose you achieved, despite that heart rate is not coming down, it becomes class 2A. You cannot use beta blocker because there is contraindication, or you are unable to uptitrate the beta blocker, again you can consider ivabradine, again it's class 2A. And this vericiguat I already mentioned. Regarding hydralazine and isosorbate dinitrate, this is a combination which has a couple of companies have brought this combination, isosorbate dinitrate with hydralazine. It's a combination. It's a potent vasodilator. Both it reduces the arterial vasodilatation it causes and venous vasodilatation. So both sides will have vasodilatation. So the cardiac output will improve and the contractility will improve. So it should be considered in self-identified black patients whose ejection fraction is less than 35 or ejection fraction less than 45 combined with a dilated left ventricle in patients who have class 3 to class 4 despite treatment with ARNI, beta blocker, MRA to reduce the risk of heart failure, hospitalization and death. The class recommendation is 2A. The same combination may be considered in patients with symptomatic HFrEF who cannot tolerate ACE-ARNI to reduce the risk of death. So patients should be considered when ARNI maximum dose given, beta blockers, MRA, everything was given, still patient is symptomatic, should be considered 2A. But when ARNI or ARB, AC cannot be used because of some reason, maybe the creatinine is very high or the potassium is very high, not coming down, or BP is very borderline, then probably you can consider one option is there, like this hydralazine isosorbate dinitrate may be considered. It has come to 2B. Digoxin may be considered in patient with HFrEF in sinus rhythm despite treatment with ACE inhibitor, beta blocker, MRI to reduce the risk of hospitalization. So here very clear, it doesn't reduce the mortality, rather it increases the mortality. So that is why only to reduce the risk of hospitalization, it may be considered. The recommendation is 2B. Actually, nowadays we are not using digoxin at all. So as I already mentioned, ICD, where will you consider? So don't put every patient with MI with the ejection fraction less than 40 immediately to ICD following myocardial infarction, because as we know that you have to wait for 40 days. So the ICD is recommended as a primary prevention in patients who had myocardial infarction, who have symptomatic heart failure, whose ejection fraction is less than 35%. Despite 3 months of optimal medical therapy only, we should think of considering a ICD. And the patient MI should be prior 40 days. That is, within 40 days, don't think. After 40 days of MI only, we have to think. So more than 40 days of MI, that is important. Not that the patient develops MI and next day ejection fraction is 35 and patient is, you cannot put ICD for primary prevention. But if it is secondary prevention, then yes, what it says, ICD is recommended to reduce the risk of sudden death or all-cause mortality in patients who have recovered from a ventricular arrhythmia, like a ventricular fibrillation or ventricular tachycardia needing a shock, which caused hemodynamic instability, and who are expected to survive more than 1 year with good functional status. There is no reversible, in the absence of reversible causes, that is electrolyte imbalance or acid-base imbalance, all those things you have ruled out as a reason for ventricular arrhythmia. So there is no reversible causes, or unless the ventricular has occurred less than 48 hours after MI, then it can be considered as a secondary prevention. The class of recommendation is class 1. So this may be looking a little busy slide, but it's an important slide which says whatever I have spoken in a single slide. So the first and foremost is evidence-based pillars in heart failure treatment is ARNI, beta blockers, MRA, SGLT2 inhibitors. And when volume overload is there, you are going to consider loop diuretics. Then you are seeing the ECG. If patient has left bundle branch block with more than 150 milliseconds, that is YQRS, you are going to consider CRT-P or CRT-D. If patient has LBBB, the green color indicates class 1 indication. The yellow color indicates class 2A indication. So if patient has LBBB, but the duration is 130 to 149, then it becomes class 2A. If patient has ischemic etiology, ICD is indicated, which is class 1. If patient has heart failure, ejection fraction is less, but it is non-ischemic, then ICD is 2A. Then if patient has atrial fibrillation, class 1 indication, anticoagulation. Atrial fibrillation, digoxin class 2 and PVI class 2. Then coronary artery disease, CABG, class 2A. That is heart failure with coronary artery. Heart failure with iron deficiency, FCM, ferric carboxymaltose, class 2A. Aortic stenosis, TAVI or surgery, class 1. Mitral regurgitation, transcutaneous mitral valve repair, class 2A. And heart rate, if it is more than 70, using evaporating the heart failure, class 2A. Black race, consider hydrolyzing with isosorbate dinitrate combination, class 2A. And patients who are not tolerating ACE inhibitors, then consider ARB, class 1. And in selected patients who have advanced heart failure, consider heart transplantation, class 1. Consider MCS, mechanical circulatory support, as a bridge, class 2A, and long-term mechanical circulatory support as a destiny therapy, then class 2A. And to reduce the heart failure hospitalization and improve the quality of life for all patients, it is recommended exercise rehabilitation is class 1, multi-professional disease management is class 1. And again, the same thing is repeated in the slides. So I'm just and this slide again shows that patients who have mildly reduced ejection fraction or the mid-range ejection fraction, again, using diuretics becomes class 1, but using ACE inhibitor, ARB, beta blocker, MRA, or ARNI, all comes at class 2B. The level of recommendation is C. So the key changes from 2016 to 2021 ESC guidelines as far as heart failure is concerned, new class 1 recommended therapy for HFrEF, SGLT2 inhibitor, DAPA or MPA. 4 key drug therapies should be initiated as quickly and safely as possible. What are those 4 key? ARNI, ACE inhibitor or ARNI. Then comes the MRA, beta blockers, MRA, SGLT2. 4 pillars or 4 key drug therapies. Importance of tailored management. That is, you have to upgrade the evidence-based medication to the maximum tolerated dose. So, in order to do that, you have to call the patients 1 to 2 weeks after the hospitalization. So, importance of tailored management. Then, primary prevention of ICD in non-ischemic cardiomyopathy. Now it has become 2A. Emphasis on broader the LBBB, better efficacy of CRT treatment. So broad LBBB in selecting CRT. If LBBB is not that broad, CRT has become class 2A. But if LBB is broad, then it becomes class 1. And change of the term heart failure with mid-range ejection fraction to heart failure with mildly reduced ejection fraction. So slightly they've changed the terminology. Thank you, and we'll take the question at the end. Over to you, sir.
Thank you, sir. Thank you, Dr. Srinivasan. May I request Dr. Girish to kindly start with your talk?
Thank you, sir. Thank you, Srinivasan, sir, for that broad outlook and overview of the latest change in guidelines and the new drugs that we have on board, as you clearly defined and mentioned in your talk, and have introduced this molecule. And my job was relatively simple. I would like to proceed with the discussion from the point where these new drugs have come into place and the kind of therapies that we can day-to-day use in our heart failure patients, right from the treating physician to the referral specialist at all sectors, where this new form of therapy is now changing the way we are treating heart failure day in and day out now with the introduction of this new class of molecule. So my topic is specifically on the focused on this particular drug, dapagliflozin, and optimization of heart failure treatment with dapagliflozin is the agenda of the discussion. We are trying to apply whatever evidence that we have into clinical practice to help us understand with this molecule where to place it and what form of therapeutic strategy that we want to use with this drug. So it all goes to the beginning again, that despite the improvement in therapy that we have over the years, we still know that heart failure with reduced ejection fraction has a high morbidity and mortality. In the ESC study, pilot study, about 12-month mortality close to about 20% for people with the ambulatory class, and the mortality rates are much higher when you have patients who have hospitalization. And even in the latest trial paradigm, which is a newer trial with all the newer drugs on board, there was residual heart failure, hospitalization, and death was still high in even in the group with ARNI. So despite the use of good therapy, we still see that heart failure is not completely curable. It leaves behind a lot of morbidity and mortality, and we need newer drugs as and when they come to be introduced and with minimalistic side effects so that they can enable our treatment. Just to highlight on a particular drug, as sir had already put in about the key things, and we can see that some people in most of us practice guideline directed therapy. So this example of a case where patient is on 25 milligram of carvedilol, pramipral, spironolactone, furosemide, and almost most of the standard forms of drug therapy with an ejection fraction of 25%. Do we still have any other drugs that we can add on? And that would be the idea of the discussion that comes on from here. There has been a change in the use of ACE inhibitor to ARNI either as a replacement or as an upfront drug. Now, that is a newer practice that has come with us in the last 3-4 years or so. From the paradigm heart failure, we know that ARNI is superior to ACE inhibitors for that matter, and that would be a good indication. But there are other situations where you may not be able to shift to an ARNI. You may have a low blood pressure, very low blood pressures for this ambulant patient, and where you may be skeptical about introducing a drug like this. So, can we do something differently? So probably one choice which can also now can be recommended is an addition of an SGLT2 inhibitor at this stage itself. And looking at the treatment options of heart failure with reduced ejection fraction, we know that the evidence-based therapies have been so because of their benefit not only with regard to reduction of the morbidity of heart failure, which is also with the gross reduction of mortality. And you can see ARNI for 20%, beta blockers 30%, aldosterone reductors another 30% reduction. SGLT2 inhibitor, another drug which has now shown about 20% reduction in mortality with heart failure. And you can see the number needed to treat for these drugs that is the number of people that you need to treat to show the difference. It is actually a good number of only around 22 for the SGLT2 inhibitor class as such. And especially we know that with increasing heart failure admissions, there is a higher rate of mortality and morbidity that happens with most of the heart failure patients. And after the first event or so, the mortality really goes up. The morbidity and risk of rehospitalization goes up. So the therapy that we now depend upon should not only be good for reduction of mortality, they should be also helping us to reduce the chance of rehospitalization. So the expanded composite cardiovascular death, heart failure, hospitalization, ED visit, or increasing therapy needed to treat these patients was seen to be about reduced by in the drug sacubitril valsartan of the order of about 20%. Still, you can say that 30% of the time you may still have patients who have patients with reduced fraction and mainly mild symptoms experiencing some worsening over a period of 3 years. So if you read behind the lines, you can understand that despite best therapy, there is always residual risk remaining with these patients. And also the two modes of death that happen in heart failure patients are not just the worsening of heart failure, there is also an instance of sudden cardiac death. And that was shown in this trial with Paradigm to have reduced to about 20%. And so these kind of therapies have changed the way we are treating heart failure to enable the quality of life to be more. And we need to add on drugs which can actually improve it further. And just a question that we can try to answer as we discuss further would be the following. Can they reduce the combination of hospitalization for heart failure and cardiovascular death with regard to the data that we have with SGLT2 inhibitor? Did they really improve on mortality, or they do only improvement only in the younger class of people? So these are some questions which we'll go through. As we know from the slides, we probably try to get in and discuss it as we go further. And again, the recommendation in the ESC has come in favor of diabetic and heart failure with regard to this drug over and above the use of metformin. Once you are in a diabetic and a risk of heart failure, even if you have heart failure or without it, when you are having the cardiovascular risk factors for heart failure, it's a class 1 indication to use this drug. And with heart failure, without doubt, we need to use it. And now slowly this class of molecule SGLT2 is moving away from diabetes per se and has become a heart failure drug as such. Yeah. So why we all revolve around this SGLT2 is that this is a reasonably new class of drugs where the multiple cardiovascular outcome trials, any new OHA that was introduced had to go through the cardiovascular outcome trial after the episode that happened with rosiglitazone, where they had increase in mortality with the use of this drug in a large population of diabetes. So they had to go mandatory CVOT, cardiovascular outcome trials, to prove the safety of these new classes of drugs. And hence it was a serendipity that was found that SGLT2 significantly reduced the risk of heart failure and diabetes, varying beneficial risk of varying classes of baseline cardiovascular risk. For example, the EMPEREG outcome trial, which studied on empagliflozin, showed about close to 30% reduction. Canagliflozin, again 30-35% reduction. DECLARE-TIMI, which is a trial for dapagliflozin, showed about 27% of 20% reduction of all the primary outcomes. The primary outcome for cardiovascular death, heart failure hospitalization, or urgent heart failure hospitalization by diabetes status was no different actually. So it is hence found that the DAPA-HF trial, they later discovered that with or without diabetes, there was almost 25% reduction of mortality outcomes and heart failure urgent visit hospitalization outcomes with regard to the use of this over and above the use of placebo. And in DAPA-HF trial, it's a major trial which leads us to the use of this molecule for heart failure population, leading away from diabetes per se into heart failure alone with or without diabetes, is the other thing that outcome that was seen along with the benefit that it conferred with heart failure, that is regarding the composite kidney endpoint. This was also beautifully demonstrated in the DAPA-CKD trial, where also there was a significant reduction in the hazard ratio was 0.7, which is very substantial with regard to the benefit from cardiovascular death and worsening of heart failure, and as well as the improvement in the kidney outcome. So this drug not only helped to improve a heart failure better, just like an ARNI would do, it also helps to improve the renal outcomes. And this is the primary composite endpoint that there are various subgroups, and it's very interesting to see that most of the subgroups, irrespective of the type, that is whether the patient was in a worsening class or patient had very low ejection fractions or just mildly reduced ejection fraction, this class of drugs seem to have benefit beautifully all over the spectrum and favored dapagliflozin over placebo. This class, the effect of outpatient worsening of heart failure data from DAPA-HF also suggests that all the points are very closely favoring dapagliflozin, like heart failure hospitalization, urgent heart failure hospitalization, visit, cardiovascular death, hospitalization together, all put together. Also, this had a substantial benefit. There you can see the p-value of the order of 0.001, which is quite substantial. And if you put this all together, the benefit seems to be starting to happen very early. For 4 weeks or so, you can start seeing the benefit. The hazard ratio, the curves separating widely in favor of the drug very early on, and it's maintained over the next 100 days or so. So that shows the benefit of this kind of drugs. And this is not unique for dapagliflozin alone. If you look at the gliflozins, we have evidence from the other class of drug, which is also approved, and as was shown by the ESC guidelines by Sir about empagliflozin, the trial EMPEROR reduced, and they had studied these two drugs particularly for heart failure in these two trials, the DAPA-HF and EMPEROR reduced, and most of our extrapolations are based on the information from these two trials. And you see that there are pretty good similarities between these trials, and when you have a few differences that could be made out would be the prior hospitalization being about close to 47% in the DAPA-HF trial, or 30% in this. This would be one difference that could be said between the two. So, per se, for worsened VEF class of patients with prior heart failure hospitalization, probably dapagliflozin has the slighter edge, but as a class, these two molecules have benefit with regard to this form of therapy as an addendum to existing therapy. And SCLT in ambulatory patients with heart failure and reduced ejection fraction, again, just to compare and see that both the drugs have shown a significant reduction, close to 25% reduction with regard to cardiovascular death, worsening heart failure events, and heart failure hospitalization. So these two classes of molecules have changed our therapy for heart failure, and this has been shown to be irrespective of type 2 diabetes presence. So essentially, these drugs began as diabetic molecules. Slowly, they have paved the way to improving the outcomes in heart failure per se. And again, looking at a summary of the DAPA-CKD means this is a significant reduction in the risk of cardiovascular secondary outcomes of death and heart failure hospitalization, as well as all-cause mortality benefit was also seen with regard to this drug. And the effect on renal function in DAPA, though there is an initial decrease for the first 14 days, subsequently we can see that the further decline in GFR does not happen, and this is true for both the diabetic arm and the non-diabetic arm. And the secondary composite outcomes of sustained more than 50% decrease in eGFR, the end-stage kidney disease or renal death were all no different from as compared to placebo. It was in fact substantially favoring. It was not an adverse effect that happened. It was more of a substantial benefit, and hence the analysis from the DAPA-CKD all suggests that with cardiac disease, heart failure, and renal disease, these are becoming slowly the drugs of choice for this kind of classes of people. So it's also vital to know, when you have such options going about, to also look at what form of therapeutical adverse effect that you may be also expecting in these class of people. We are worried about serious adverse effects like diabetic ketoacidosis and major hypoglycemia, which seem to occur with very little kind of severity in this large population that was studied, about close to 3,000 patients or so in either arm of the trial, and they had very little renal adverse effects or adverse effects like major hypoglycemia, which would be the key areas of interest that we would have with regarding to the use of the therapy on a long-term basis. Essentially, so to speak, all this points to the fact that these drugs are having a relatively good safety profile and helps us to use them judiciously in most of our heart failure patients without serious worries. Only concern probably would be with regard to a slight increase of genital infections, and these are some of the pre-specified side effects that we noticed in the EMPEROR reduced trial, where also they showed there was some mild increase of genital infections. And this is an interesting analysis which looked upon the use of several classes of molecules together to see whether it prolongs life. And this analysis by Vaduganathan and colleagues have shown that once you put on these drugs, compared to the older school of ACE, ARB, beta blockers, when you use a comprehensive treatment, and now comprehensive treatment would be these 4 pillars of therapy, the ARNI beta blocker, melanocortical receptor, and the SGLT2 inhibitor. This whole together put in with regard to the reduction of hospitalization and cardiovascular death would essentially mean that if you look from all the analysis, you change the therapy from ACE to an ARNI, you use MRAs and use SGLT, you improve the patient's life and extend your patient's life by quality of 6.3 years. So that's a substantial improvement with this kind of therapy that we have on board, coming from what we would do a decade earlier. And an ideal heart failure medication should probably have these characteristics. And probably SGLT2 would fit into this. It does not reduce blood pressure significantly. And many of these patients have a borderline blood pressure, especially with the use of beta blockers and ARNI. The scope of adding an additional drug, which would have an effect on hypotension, would be a serious harm. And that is not seen with SGLT2. That is the beauty of this kind of molecules. One pill once a day and no dose titration. So this again gives us a lot of scope for adding other drugs along simultaneously, and in the sequence of guideline-directed therapy, where you might take more time to upfront reach the targeted dose over weeks for most of the other classes of molecules like ACE or beta blockers or ARNI, where you might take about 6 weeks or so to 6 to 8 weeks or so. By that time, SGLT would have already been into its full action by initiating very early on in therapy. So this gives us the option of using this very early on along with the other drugs. And so to speak, this is just an extension of the same thing, that if you delay the drug therapy by about 3 months or so, you will increase the mortality of many of these patients. And so we should probably use these drugs very early on. And that is probably the new concept of the accelerated use of this drug. And there is a small discussion coming up in certain societies about the use of this form of a new regime, where we talk about SGLT and beta blocker, and then add on with the ARNI and the middle. This is it's only coming into play, but we always look at the existing accepted guidelines, where they have looked upon this as probably the newer way of strategy of adding all these drugs and considering them as not as a separate or a series of addition, and try to add on these drugs upfront as and when possible if these people are not on any of these forms of therapy. And this would really give us a substantial benefit, an additional 20% benefit. So the cumulative risk reduction and mortality in all evidence-based therapies are used. The relative risk reduction is about 70%, the absolute reduction 25% with just NNTFO. So that is when you combine or cumulatively use these forms of therapy to the best advantage. So now a consultant should probably always try to leave the inertia behind and try to use all guideline-directed therapy to the best potential, and probably have an SGLT2 in that arm of therapy also. And this first major guideline that introduced this was the Canadian guidelines, where they showed that this is the fourth in the list of the first 4 drugs of standard therapy for reduced ejection fraction. And if you look at other recommendations also, they have seen that along with the latest therapies, all these therapies have shown as a must-do of using this SGLT2s inhibitors right up from there. And an update on the ACC 2017 ACC expert consistent decision pathway. Again, there is a solid recommendation for the use of these kind of drugs. If you look at the indication for SGLT2, heart failure with reduced ejection fraction with or without diabetes has become in the classes of 2 to 4 NYHA. We have to use this drug in the conjunction with the background of guideline-directed therapy. So that's how the guidelines have now evolved, and almost ARNI in conjunction with the background of heart failure therapy and changing from ACE to ARB has also become a significant recommendation from many of these societies. And SGLT2, probably we need to be cautious only in a few circumstances. Generally, a safe drug to use is not used for diabetes type 1, insulin-dependent diabetes mellitus, due to the high risk of DKA. Known hypersensitive drug could be a contraindication. And you can see that probably an increased risk of myocardial infarction would be a rare complication that can happen. But nevertheless, if the patient has recurrent myocardial infections, the general probably an indication to stop the drug. For heart failure care, dapagliflozin with eGFR less than 20 ml, very low GFR, the efficiency of the molecule probably goes down, and up to around 20 or 30 ml, you can have the freedom of using these drugs. But below that, probably the role may be questionable. And the use of SGLT2 early or even first would seriously be a thought process that will now come into our mind, having seen through what the guidelines have suggested and what the trials have now, randomized trials have given us insight on that this is a drug with negligible effect on blood pressure, no serious side effects, better tolerability, can be started in out of hospital also, can be begun at discharge for a recently hospitalized patient, and it over time it preserves the renal function. So often the worry is with the concept that when you add these drugs, you should not worsen your heart failure and renal failure outcomes. You have to be careful sometimes with the over-diuresed patient who's dehydrated, who's been recently started on an ARNI or ACE inhibitor. When you add this drug in the first 2 weeks or so, there is a slight stress on the kidneys. But if you look at that carefully, many of these drugs can be the fantastic 4 pills for therapy. As we now look at beta blockers, mineralocorticoid receptor antagonists, SGLT2, and the ARB plus neprilysin ARNI as the key drugs for therapy. I'll just summarize a few more slides before I wind up on to bring up the discussion on this aspect of SGLT2 in preserved ejection. This is the other thing that is coming up. So far, we did not have any good drug therapy for heart failure with preserved ejection fraction. Most of the guidelines have not met the criteria to suggest that these could be the drugs of choice for this class of molecules. But now, with latest analysis and data coming up from trials, one from the Circulatory trial, where they showed benefit with regard to the use of this drug in heart failure with preserved ejection fraction. And again, coming to the Emperor preserved, there is a suggestion from the empagliflozin analysis of almost 926 patients. Of this, of these, 611 were heart failure hospitalization before or on the day of death, and significant reduction of heart failure benefit was seen with this drug, and slowly becoming a drug for heart failure with preserved ejection fraction. Similarly, we have the evidence from DELIVER trial, the dapagliflozin evaluation, which is the study is not yet out, expected in 2022, but again, another class of molecule in a bigger study where they are looked upon reasonably preserved ejection fraction more than 40%, and looking at the outcomes and with the kind of class effect seen with the other two molecules, dapagliflozin is also head on with this, most likely to be in the direction to get the same approvals. And determine preserved is another trial which looked at dapagliflozin on exercise capacity on top of the other standard of care therapy for heart failure. And in heart failure with preserved ejection fraction, again seen that the use of this drug showed improvement in the functional class. And the preserved heart failure trial, it's a small trial, about 600 patients, which is again after you had about 150 patients on either arm. It again is inclusion criteria of heart failure with NYHA class 2 symptoms and ejection fraction more than 45%, with the use of pro-BNP also, a requirement for dietary therapy and a recent hospitalization to qualify for this therapy. Again, there was substantial improvement in the functional class, the 6-minute walking. All this proportionate had a good difference in the arm, and there's very significant p-value for this change in the functional score over a 12-week period of significant order of close to 10 points or so. And whenever you have a change in 5 to 10 points, it's a substantial change in this when you use this class. And again, this evidence is for dapagliflozin for preserved heart failure. So coming to the overall understanding of the use of this drug, it improves the quality of life, improves the functional class of the patient in both forms of reduced ejection fraction, as well as now recommendations evolving towards heart failure with preserved ejection fraction. Also, especially small trials have now shown bigger trial DELIVER is also expected to give light into that, and Emperor Reduced has already shown, Emperor Preserved has already shown that there is a suggestion of that molecule to come up in big time for heart failure with preserved ejection fraction. So as a class, SGLT2 is showing evidence with regard to the benefit from heart failure reduced ejection fraction to also with heart failure with preserved ejection fraction, prevention of heart failure development in diabetic population, prevention of heart failure in CKD population. So the spectrum of this molecule is really widening day by day as we get more and more information and incorporate this into clinical practice. So I would like to summarize here, and added to standard of therapy, heart failure with reduced ejection fraction care, SGLT2 inhibitors like dapagliflozin reduce all-cause mortality and heart failure hospitalization without serious adverse kidney outcomes, and significant benefit with regard to the kidney outcomes also, with regard to the reduction of EGFR or the preservation of the kidney function, less than 50% decline or development of end-stage renal disease in heart failure. These drugs are now becoming the standard of care. The total evidence from DAPA-HF is clearly an indicator for the use of dapagliflozin in reducing all-cause CV mortality. The benefits are seen irrespective of age, sex, and irrespective of the presence or absence of diabetes, whether you're treating with ARNI or not. So it just shows that it's definitely an addendum to the existing therapy and without serious concerns. And probably, I think I will leave you with this question now, that probably with the available information, I think most of us could be really confident on using up this drug, and that's probably for all of you to answer. Thank you. Be happy to share and discuss.
Thank you so much, sir. Thanks, and that was truly brilliant. With your kind permission, we'll just kind of take a quick pause here, and I'm just going to share polling questions for the audience. There are 3 questions which are going to appear on the screen, and for each of the questions, we are going to have a 10 seconds time. So, dear doctor, all of you in the audience, on left-hand side of your screen, where there is a icon called Ask Questions, there is also an icon just beside it that is polling. So, if you just kindly click on that, these questions will appear on your screen. So, once this question appears, and I'm going to show these questions, it is going to be there for the 10 seconds. So, you are just kindly request to answer that, right? There will be only 3 questions, right? So hope you must have, could locate that polling questions, right, on that icon, left-hand side of your screen. So here we go with the first question. In your clinical practice, what percentage of the patients develop heart failure in their lifetime? The option A is below 10%, option B 20 to 30%, option C 40 to 50%, and option D more than 60%. Your time starts now. Well, thank you. We come to the second question. When do you consider initiation of SGLT2 inhibitors treatment in your heart failure patients? Option A, only in case of diabetes with HFrEF. Option B, post-stabilization after detection of HFrEF irrespective of diabetes. Option C, HFrEF with borderline blood pressure irrespective of diabetes. And option D, heart failure irrespective of ejection fraction. Your time starts now. Well, and then here we go with the last question, which is very simple, straightforward. Do you consider initiation of statin therapy in your heart failure patient? Only 2 options, yes or no. Your time starts now. Thank you so much. Thanks for your active participation. And here we request Dr. Srinivasan sir and Dr. Girish to kindly put forward your comments. And we have not yet received any questions, sir, from the audience. So if you can just put forward your comments on the topic.
You mean to say these questions which you have put?
Yes, this question as well as any other further comments and the opinion from your end, right, sir?
I think this is an extensive meeting. I think, we have covered the volume. I think,
Yes.
So I don't think audience will have any more doubts. So the first question which you have put, the heart failure lifetime risk is maybe about 20%, I think, 20%. And the second thing is, the option B, the second slide, which is on option B, that is patient who have HFrEF and irrespective of diabetes, when they are stabilized, we can consider this one. And the third thing is, statin usage in heart failure, if it is indicated, definitely it is yes. So,
right,
yeah. Thank you, sir, for that. I think you have elaborated on the ESC guidelines beautifully, where most of the other key things were discussed. So, and SGLT probably is making space into all forms of heart failure. Probably the question revolved around that aspect also, that other forms of heart failure probably would be a growing indication. And since we do not have much drugs on board for heart failure with preserved ejection fraction, and the entity which is also being released, these classes may be taking a space there. But as of now, as per all guidelines, what we have class 1 would be for reduced ejection fraction, as sir rightly mentioned there. And regarding, I think based on the type of practice, different physicians have different heart failure lifetime. Probably the diabetologist would be feeling that there would be about 20-30% of people in their lifetime developing heart failure. So I think sir also initially mentioned about this class of molecules, gliflozins, as the drug which is now preventing the onset of heart failure in the diabetic population. Not only for people with heart failure, also even without heart failure, the prevention of heart failure, which is becoming a growing recommendation. So all in all, I think this discussion has enlightened me personally also on the widening the use of these two, an upper class of EF also, and rather than restricting to lower ejection fractions from as the evidence is now building up. And definitely this would be one of the first steps of choice along with the other pillars.
Right, sir. We have the polling results, sir, in front of us, right? Just for the, quick view of it. So this was the first question.
Yes.
I think perfectly, most of the people have said 20 to 30%.
Yes, right, sir. And next question was this, and this is the answer of the next question.
I think 50% have said HFrEF with borderline BP.
Yes.
I mean, if you see here, 33% have said post-stabilization, HFrEF, irrespective of diabetes.
That 16% is only a small expanding indication, but I think slowly the thought is towards getting it for all forms of heart failure, maybe as we get more information from future trials too. And
this slide, the best thing is 0% only in case of diabetes HFrEF. So they got the that's the main thing. Nobody has selected the first one, so that is good. So people started using it in the right indication.
Right.
From a OHA to a heart failure molecule, the transition is happening for dapagliflozin or other gliflozins from a OHA to a heart failure molecule. So that aspect is delivered there.
Right, sir. And the last one, actually, we received, unanimous yes for statins. Any comment from your end?
Sir, there is some data regarding the initiation of statin and heart failure about not so beneficial, at least if you just without significant CAD for heart failure alone. There is some data, some registry or information in that lines also. So probably I thought the question was to bring out that aspect. Though there is, of the cardiologist, we definitely give statin. But if a patient is a heart failure, not a CAD, what is if the question is revised as a non-ischemic or a non, and then the recommendation actually goes down for, if I am not wrong, there is some discussion like that. Sir, what is your take on that, sir? Without
that is absolutely correct. Yeah.
Right, sir. Sure. So thank you so much, sir. It was really wonderful, and thanks for your enlightenment on this particular topic. It is very recent, these guidelines, and there are very many key insights which we received, and some of the key practice changing points, which is very very discrete and distinct. The updates from the 2016 guidelines. Thank you so much, sir. For having so much of insightful discussions and giving that insight for the clinicians who have participated in this meeting. Thank you, Dr. Girish, for enlightening on these particular evidences to be reviewed in dapagliflozin and its upcoming usage, particularly in the HFrEF and other aspects which you did mention. Thank you so much for your valuable time, and thanks to each one of you in the audience who had participated. And as I did mention at the very beginning, our commitment and our endeavor to continue such learning platforms will be kind of going to continue further. And thanks for your support and the inspiration for that things. With this, thank you so much, and good night and stay safe. Thank you. Thank you, Dr. Girish.
Good night. Thank you.
Good night, sir. Good night.
Good night, sir.